Hello, everybody. Hello, I am Dr. Aladdin Marawi. I'm Chief of Hematology Oncology at Gulf International Cancer Center in Abu Dhabi. It is my pleasure and honor to chair this meeting regarding current clinical oncology in Korea. The meeting will be for 2 hours. It is accredited for 2 hours of CME. The CME will be sent by email after 2 weeks. So everybody who attended will get an email. At that point, you will fill the assessment evaluation form, and then you'll get the CME. It is my pleasure to, so today we will have 4 speakers, and the flow of the meeting will be 30 minutes for each presentation, and then after that, we will have 20 minutes of discussion. The presentations will be first one, surgical approach for advanced hepatocellular carcinoma. Then it'll be treatment of solid tumors in children at Samsung Medical Center. Then patient care post-allergenic stem cell transplant in pediatrics in Korea. And the last presentation will be regarding robotic surgery at Yonsei. Yonsei is it's a university, Yonsei University College of Medicine in Korea. So we will get started. It is my honor to present Professor Ji Won Song. He is MD and PhD. He is professor in the Department of Surgery, and he works at Asan Medical Center. The presentation will be titled Surgical Approach for Advanced Hepatocellular Carcinoma. Professor Song, please, the podium is for you.
Hi, everyone. It's a great pleasure and honor to share our experience in surgical activity in treatment of HCC. I'm Gi-won Song, a transplant and hepatobiliary surgeon working for Asan Medical Center, Ulsan University College of Medicine, Seoul, Korea. Today, I'm going to talk about the surgical approach for advanced hepatocellular carcinoma. First of all, I'd like to talk about what's the advanced HCC. The meaning of advanced is a little bit vague. There has been no uniform or universal consensus about that. It's a very subjective categorical term. It might be different from the viewpoint of treatment provider. According to the therapeutic guidelines of HCC, main factors determining the disease status include tumor size and number. The higher number and bigger size usually means advanced stage. In addition, the vascular invasion always means advanced or sometimes far advanced stage. This is a Japanese guideline. The Japanese Society of Hepatology recommended non-surgical treatment as a primary option if the tumor number is more than 3 and vascular invasion exists. They didn't suggest a clear cut-off value of the tumor size regarding the treatment option. This is a Korean guideline. The Korean Liver Cancer Study Group also suggests a similar therapeutic guideline according to the tumor number, size, and vascular invasion. This is one of the most famous therapeutic guidelines used in the actual clinical practice. The Barcelona Liver Cancer Group, the BCLC, the staging and treatment guideline. The Barcelona group categorized the tumor with vascular invasion, nodal invasion, or distant metastasis as advanced stage. In such a situation, they recommended the sorafenib as primary treatment option. As you can see in this guideline, the surgery, hepatectomy cannot be chosen as a primary treatment option for HCC, the high number, the vascular invasion, or other signs of systemic dissemination. However, the surgeon's interest or viewpoint for advanced HCC is a little bit different. Our major interest is if hepatectomy can be a feasible option or not for the patient. And advanced features from the surgeon's viewpoint include large size and vascular invasion. Huge size and or vascular invasion, such as portal vein bile duct or hepatic vein tumor thrombosis has frequently evoked some argument about feasibility or beneficial impact of the hepatectomy. In such conditions, the role of hepatectomy assigned to the gray zone. So today I'd like to talk about the role of hepatectomy for huge HCC and HCC with vascular invasion, so-called locally advanced HCC. What's your first impression about surgery? Dangerous, painful, destructive? However, the surgeon is not dangerous from the viewpoint of the surgeon. The surgical resection is the most reliable treatment option for hepatocellular carcinoma. It has verified its therapeutic efficacy for a long time and served as a golden standard of treatment for HCC. Nevertheless, there are concerns about technical feasibility and operative risk because most advanced HCCs require very complicated and extensive surgical procedures. Furthermore, the surgical handling can potentially provoke systemic dissemination or spread of tumor cell. So we must have the confidence about the safety of the operation and the survival benefit of the hepatectomy to avoid futile operation. Particularly, we must pay attention to minimize the operation risk of patient. So we have to do a very precise preoperative evaluation of the disease status, underlying liver function, and then generalize the operative risk of patient. And we need very skillful surgical technique, and we have to apply meticulous surgical technique in the surgical field. And intensive post-operative care is important as well. First, let me talk about huge HCC. Looking at many reports about the surgical outcome of a huge HCC, the early recurrence rate was high as expected. As you can see in this table. But reported long-term survival outcome has shown acceptable ranges. The reported operative mortality has ranged from 2 to 8%, and 5-year patient survival rate ranged from 17 to 15%. The long-term outcome of repeated TAC for huge HCC was much worse than that of surgery. In one Taiwanese study, TACE for huge HCC showed significantly better outcome in comparison with the supportive treatment, but long-term survival rate was very low. In their study, 3-year and 5-year patient survival rate was 12.9 and 6.5% respectively. In the Hong Kong study, the median survival after TACE for huge HCC was just 5.6 months, and we couldn't expect long-term survival in patients with huge HCC and combined underlying hepatic dysfunction. Our hospital have reported our experience of the surgical outcome in huge HCC in 2007. This study included 845 HCC patients receiving hepatectomy. Among them, 107 patients, 14.1%, showed huge HCC. They underwent various kinds of the hepatectomy. The 80% was the anatomical resection, and 20% was the hepatectomy combined with the other organ resection. The actual 5-year patient survival rate was 31%, and disease-free survival rate was 20%. In risk factor analysis, the microscopic and macroscopic vascular invasion were significant risk factors for worse outcome. Interestingly, even the patient who experienced the recurrence after hepatectomy for huge HCC showed significant better survival outcome after the active treatment. The gross feature and total number of the tumor can affect the survival outcome after hepatectomy for the huge HCC. In the Hong Kong study, the single nodular huge HCC without vascular invasion showed significantly better survival outcome. Therefore, we must actively consider surgical resection as the first treatment option, even in patients with huge HCC. If hepatectomy is technically feasible, the patient can have a chance for long-term survival in selected case. Let me show you one interesting case. The 46-year-old male patient complained of the right upper quadrant pain. The preoperative CT scan showed huge mass occupying segment 4, 5, and 8. His liver function was normal. There was no evidence of the liver cirrhosis or hypertension. We performed central bisectionectomy in this patient. It was a very complicated operation because of huge size itself, and compression of the vascular structure by mass, and deviation of vascular and biliary anatomy. But the operation was successful. The patient has survived disease-free more than 10 years. So whenever we are encountered with the patient, such patient with huge HCC in the clinic, we must think about the hepatectomy first, because most of patients with huge HCC showed preserved underlying liver function, and other local regional treatments are not feasible. Most patients complain of the symptom which can affect quality of life. And huge HCC always has potential of serious complications such as rupture, bleeding, abscess formation, etc. And the OP risk of hepatectomy has become acceptable recently, even in patients with huge HCC. The next topic is vascular invasion. There has been many controversial issues about the beneficial impact of hepatectomy for HCC with the portal tumor thrombosis. In Conside, they insist that HCC with portal tumor thrombosis is a high risk for post-resection recurrence and showed unacceptable long-term survival outcome. And they also insist that surgery has high operative risk in such a patient group. In Proside, they question that the outcome of other treatment modalities such as TACE or radiotherapy or RFA can surpass that of the surgical resection, and they also question the increased operative risk by itself really. In Japanese the surveillance study, we can see the substantial number of the 5 and 10-year survival rate after hepatectomy for portal vein thrombosis. If portal vein tumor thrombosis is limited to second order or third order branch, the 5-year survival rate was 39 and 24% respectively. We cannot expect such result in another non-surgical treatment for HCC with portal vein tumor thrombosis. So hepatectomy might be only chance for long-term survival. In this large-scale retrospective study, they compared the survival outcome between the liver resection and non-liver resection group in the patient with the HCC with the portal vein thrombosis. Liver resection group showed much better outcome, but looking at the patient characteristics, you can see significant difference between the two groups, especially in underlying liver function and tumor number, size, AFP level, and the portal vein tumor thrombosis location and extent. However, the liver resection still showed a significantly better survival outcome even after the adjustment of the risk factor which may affect survival outcome. In risk factor analysis with the Cox regression, liver cirrhosis, tumor size, and number of tumor over than 3, the AFP level, and location of the tumor thrombosis, and resection margin, there were independently significant risk factor for survival after hepatectomy for HCC with the portal vein tumor thrombosis. In our experience, we can find out that surgical resection enable us to achieve the best survival result even in patients with portal vein tumor thrombosis. In multivariate analysis, the patient age and the gender, the number of tumor, and surgical resection were independently significant risk factor for survival after treatment for HCC with the portal vein tumor thrombosis. So, Korean guideline proposed by the Korean Liver Cancer Study Group recommended that the hepatectomy can be considered even in patients with portal vein or hepatic vein or bile duct tumor thrombosis if the liver function is well preserved and the number of HCC is less than 3 and there is no main portal vein invasion. Let me show you another case of advanced HCC with the portal vein tumor thrombosis. This 52-year-old male complained of right flank pain. The pain was very severe. He was the herpesvirus carrier. There was no evidence of the hepatic dysfunction. In the CT scan, the huge HCC replaced the whole extent of light lobe. There was extensive portal vein tumor thrombosis spread to main portal vein, but there was no evidence of the invasion, tumor invasion in the left side. So you can see the huge mass in this picture. We did a highlight dissection first, and we divided portal vein. And we also did portal vein thrombectomy and the portal vein venoplasty to prevent portal vein stenosis after operation. And we completed right lobectomy. This slide is summarizing the actual principle in real practice. The hepatectomy can provide acceptable long-term outcome for the patient, even with portal vein tumor thrombosis, if following conditions such as the no contralateral portal vein tumor thrombus, no intrahepatic metastasis, arterial resection, and no significant portal hypertension can be fulfilled. Next, I'm talking about HCC with the bile duct tumor thrombus. Sometimes we can see the patient, HCC patient with jaundice. The reported incidence showed very wide range, from 5 to 45%. The hypobilirubinemia in HCC patient can be classified into two types, hepatocellular type and icteric type. In the hepatocellular type, the hypobilirubinemia is mainly due to underlying liver dysfunction or extensive hepatic parenchyma infiltration. So 90%, over the 90% of HCC patients with jaundice belongs to hepatocellular type. In such a patient, life expectancy is within 10 weeks. But icteric type is due to obstruction of bile duct by tumor or tumor thrombus. From 2 to 9% of HCC patients belong to this subtype. In such a patient, surgical treatment may be beneficial. Professor Gvhd classified icteric HCC into 4 types according to the location and extent of bile duct tumor thrombus. The segmental, the tertiary order branch involvement belong to the type 1, but segmental branch, the second order branch involvement means the type 2, and first order branch involvement means the type 3. The type 3 biological behavior of types, clinical manifestation and the behavior of type 3 icteric HCC is similar to that of the hierarchical angiocell carcinoma. Hypo means the diffuse involvement of bile duct thrombosis in HCC patient. In his study, he reported that the bile duct tumor thrombosis affected significantly significant negative impact on survival outcome. The reported patient survival 1 year, 3 year, and 5 year patient survival rate after hepatectomy for HCC with bile duct tumor thrombus was 62 and 30 and 30% respectively. The disease-free survival was very low. The 3-year disease-free survival rate was just 7% in patient group with bile duct tumor thrombosis. We also analyzed the surgical outcome in a patient with bile duct tumor thrombosis. This study included 53 patients with bile duct tumor thrombosis, which accounted for 1.6% of all patients receiving hepatectomy for HCC. Out of 53 patients, 45% of patients were accompanied by the portal vein invasion, and 60% required preoperative biliary drainage procedure. 92.5% successfully underwent the hepatic resection. Among them, the 85% underwent anatomical hepatic resection. Overall, the operating mortality was 1.8%. In the analysis of survival outcome, we can see it relatively acceptable, the short-term and long-term survival outcome, but over than the 60% of patients eventually they experienced the recurrence. The most common recurrence site was liver, but 20% of patients experienced extrahepatic recurrence, including primary metastasis or lymph node metastasis. But just 20% of patients experienced recurrence at the bile duct, only 7%. There was no peritoneal dissemination after tumor thrombectomy. Let me show you the interesting case, HCC patient with the bile duct tumor thrombosis. This 46-year-old male complained of fever, chills, and jaundice. At the time of diagnosis, the thrombin level was 13.9, but it decreased, abruptly decreased just after biliary decompression, the PDBD and the EMBD. We underwent the right trisectionectomy and the bile duct dissection. We did the hilar dissection first, and we divided bile duct, and we removed the bile duct tumor thrombus. There has been the controversial issues about necessity of the routine bile duct dissection in patients with the HCC and the bile duct tumor thrombosis. But because most of the bile duct the thrombosis is not the actual invasion; it's just the thrombosis. So in most cases, it can be easily removed. But if there is any suspicion of the remaining tumor on bile duct wall or any suspicion for right invasion, we must not hesitate to do the bile duct dissection. In this case, we did combine the bile duct dissection. The outcome was acceptable, successful. The patient experienced recurrence after 10 months after the resection, but the recurrent lesion was well controlled by the repeated tests. The patient has survived more than 6 years. He is currently alive without the residual tumor on the follow-up CT scan. So, hepatectomy for HCC with foramen tumor thrombus and the bile duct tumor thrombus has shown the worst survival outcome, but hepatectomy might be only curative options in selected cases. But we have to think about seriously think about the technical feasibility and patient the underlying liver function before determining the operation of such a patient. This is summary and conclusion of my talk. In this treatment guideline for HCC, the role of hepatectomy for advanced HCC is very limited, but in real-world practice, the role of hepatectomy for even the advanced hepatocellular carcinoma is still valid. So we have to actively think about the hepatectomy for the primary option, even for HCC with advanced stage. But to improve the post-operative outcome, we desperately need for the effective adjuvant treatment after operation. Thank you for your kind attention.
Thank you, Professor Song, for this very informative presentation. We will leave the questions and discussion to the end. So it is my pleasure now to present the second speaker. Is going to be Dr. Ji-Won Lee, MD, PhD, Associate Professor, Department of Pediatrics at Samsung Medical Center in Seoul, Korea. She will be talking about treatment of solid tumors in children at Samsung Medical Center. The podium is yours, Professor Lee.
Good afternoon, everyone. My name is Ji-Won Lee, and I am a professor of Pediatrics Department at Samsung Medical Center. I'd like to thank the organizers for an invitation to share SMC experience with the treatment of solid tumors so far. And I would also like to thank the audience attended today's online conference from UAE. I would hope that this presentation may be helpful to you. Let me begin my presentation by giving a short introduction video of myself. 저는 삼성서울병원 소아청소년과 전문의 이지원 교수입니다. 저의 주 진료 분야는 소아암 중에서 고형암으로 신경모세포종, 뇌종양, 윌름스 종양, 육종 등의 질환을 보고 있습니다. 또한 재발한 암에서 종양 유전체 검사를 시행하여 임상시험 등을 진행하기도 하며 암소인 유전자를 가진 환자에서 유전 상담 및 추적 검사도 시행하고 있습니다. 아이가 암에 걸리는 것은 가족 전체에게 매우 힘든 일이기 때문에 힘든 상황을 이겨내는 데 도움이 되는 동반자가 되고자 노력하고 있습니다. 소아암의 원인은 아직 정확하게 밝혀져 있지 않습니다. 일반적으로는 유전적 요인과 환경적 요인이 함께 작용하는 것으로 추정하고 있으나 성인에 생기는 암과 비교할 때 환경적 요인의 역할은 크지 않습니다. 최근 연구에서는 소암을 가진 환자의 약 10%가량에서 암을 유발할 수 있는 암소인 유전자가 역할을 하는 것으로 보고되었습니다. 소아암은 종류가 매우 다양하여 일률적으로 완치율을 이야기하기는 어렵습니다. 다만 최근 들어 소아암의 치료 성적이 크게 향상되어 전체적으로 소아암의 생존율은 70에서 80% 정도로 보고되고 있습니다. Here's an outline I'll cover today. I'd like to give you a quick introduction of Children's Cancer Center at SMC and go over treatments of pediatric solid tumor we performed so far. Especially, I want to share SMC experiences with the treatment of high-risk neuroblastoma and brain tumors, which improved the survival rates dramatically. Here is a quick introduction to SMC. It is an urban tertiary coronary care academic hospital with almost 2,000 beds and 10,000 outpatient visits per day. There are over 5,000 medical professionals, including doctors, nurses, nursing assistants, and technologists, in addition to over 2,000 non-medical support staff. The Children's Cancer Center at Samsung Medical Center has 13 doctors, including 6 professors, and 36 nurses, including 2 professional nurses. We have a total of 65 beds, including 10 beds in the pediatric stem cell unit, and 40 beds in pediatric oncology ward, and 15 beds in ambulatory care center. This is the inside view of the SST unit. This is the pediatric oncology ward, where general pediatric cancer patients are hospitalized. We have a total of 40 beds. This is the ambulatory care center. Chemotherapy can be performed on an outpatient basis. Children and adolescent malignant tumors are composed of completely different kinds of tumors from adults. The reason is that the genetic factors that determine the development of a tumor are different from adults. In pediatric solid tumors, brain tumors and neuroblastomas are most common. Our hospital has a global competitiveness in the treatment of these 2 tumors. The treatment response is generally better in pediatric solid tumor than adult cancer. Another characteristic of pediatric cancer treatment is that minimizing the late adverse effect is very important, considering the children's quality of life after treatment. Common treatments for pediatric cancers are surgery, chemotherapy, and radiation. With these treatments, pediatric cancers usually have good survival rates, but outcome is still poor in some high-risk or recurrent tumors. And treatment at young age can have significant late adverse effect. To overcome these problems, we use several strategies. One is high-dose chemotherapy and autologous stem cell transplantation. Other approaches are proton therapy, targeted radiotherapy, and precision medicine based on genomics. We have genomics platform to screen actionable variants of tumor and also have several clinical trials based on genomics. The first one is high-dose chemotherapy. High-dose chemotherapy is one of the methods that can be used for the treatment of high-risk solid tumors. Samsung Medical Center has developed the tandem high-dose chemotherapy for the first time in the world, which uses high-dose chemotherapy twice consecutively to further improve the survival of high-risk or recurrent tumors. The survival rate in high-risk neuroblastoma, which was only 10 to 20% with conventional chemotherapy, increased to 30 to 40% with single high-dose chemotherapy and to 60 to 70% with tandem high-dose chemotherapy. Through these treatments, our center has the world's highest survival rates in the field of high-risk neuroblastoma. Next is proton therapy. Proton therapy can minimize the side effect of radiation therapy compared to the conventional radiation therapy. Currently, all pediatric cancer patients at Samsung Medical Center are receiving radiation therapy using protons. Next is targeted radiotherapy. At Samsung Medical Center, high-dose Cmv treatment is usually performed in high-risk neuroblastoma patients with minimal radiation exposed to normal tissues. It is a treatment to minimize the late effect of radiotherapy. We have isolation unit for Cmv treatment. Next is precision medicine. Each patient can have different genetic variations in their tumors, and if the tumor has an actionable genetic variant that can be targeted by specific drug, then the patient can be treated with a specific drug through clinical trials. In order to implement precision cancer medicine based on genomics, Samsung Genome Institute developed CancerScan, NGS-based targeted deep sequencing analysis solutions. In this next video, you will see how the CancerScan works.
The human genome is comprised of approximately 25,000 genes. And CancerScan is an NGS-based diagnostic platform that analyzes 381 specific genes related to the drug targets and prognosis of cancer. CancerScan begins with the extraction of DNA from a patient's clinical specimen. The extracted DNA is then analyzed via CancerScan platform, which is based on Samsung Genome Institute's proprietary next-generation sequencing, or NGS. Genome data specific to each individual patient is then further discussed and analyzed in depth by a board of oncologists, biologists, pathologists, and geneticists from a multidisciplinary perspective in efforts to derive the most effective drug candidates. With the Gateway system, another proprietary development of Samsung Genome Institute, a clinical doctor can verify genome analysis results via the internet and use that to plan individual treatment options for patients. The development process and clinical testimonials of CancerScan have already been published in numerous internationally accredited journals, praised for the academic values it offers.
Our Children's Cancer Center developed PET scan that can screen the genetic variants of pediatric high-risk or recurrent tumors. PET scan is a targeted sequencing panel which covers diagnostic and prognostic genes in pediatric cancer, including cancer predisposing genes. With this panel, genetic variants such as single nucleotide variation, translocation, and copy number variation can be detected. This is a representative case of precision medicine using PET scan. This patient had inflammatory myofibroblastic tumor, and no genetic alteration was detected with conventional method with FISH. The patient had multiple peritoneal seeding lesions, and the conventional chemotherapy did not work in this patient. Panel sequencing of tumor tissue was done with PET scan, and it revealed ALK TPM4 translocation. We started crizotinib, an ALK inhibitor, and this patient achieved complete remission after 4 weeks of treatment. This is another representative case with refractory neuroblastoma. In this patient, PET scan revealed activating ALK mutation and ALK amplification. The detected ALK mutation was known to be resistant to the first generation ALK inhibitor such as crizotinib, so we requested the compassionate use program to Pfizer, and the patient showed response to lorlatinib. The following topic is a brief introduction of the treatment of neuroblastoma and brain tumors, in which our hospital has global comparativeness. Neuroblastoma is the most common pediatric solid tumor except for brain tumors. The survival rate of high-risk neuroblastoma is only 10 to 20% with conventional treatment. Survival was improved with single high-dose chemotherapy, but the outcome was still unsatisfactory. Therefore, our center developed tandem high-dose chemotherapy for the first time in the world. This is a report of our early experience in the early 2000s, where the survival rate has increased to over 60%. This is the result of patients who were treated for 5 years since 2004. The 5-year survival rate has been improved to over 70%, but late effects of treatment were also significant. So for 5 years from 2009, we developed a new protocol which incorporated high-dose Gvhd treatment into tandem high-dose chemotherapy. This is the backbone of our high-risk neuroblastoma treatment protocol. We use 6 cycles of pre-OP chemotherapy, surgery, 3 cycles of post-OP chemotherapy, tandem high-dose chemotherapy, local radiation, and immunotherapy. The only difference between the MB 2009 study from MB 2004 study was that total body irradiation in the second high-dose transplantation was replaced by the high-dose Gvhd treatment in the MB 2009 study. This study significantly reduced late adverse effect while maintaining survival rate. This treatment was the first prospective study that incorporated high-dose Gvhd treatment into tandem high-dose chemotherapy as a frontline treatment in high-risk neuroblastoma. And now since 2014, we have implemented a tailored high-dose chemotherapy which use different intensity of high-dose chemotherapy regimen according to the pre-transplant responses. Although the follow-up is not enough, the survival rate is close to 80%. Death from treatment complications have been significantly reduced, and the late effects were less than before. And in case of relapsed neuroblastoma, we have used allogenic stem cell transplantation. And some patients survived even after relapse, especially if the Cmv treatment was incorporated, or if the pre-transplant treatment response was good. Approximately 40% of patients survived. Next, I will talk about the treatment of high-risk brain tumors at Samsung Medical Center. Pediatric brain tumors are usually treated with surgery, radiation, and chemotherapy. However, brain tumors with large residual tumors, leptomeningeal metastasis, or unfavorable histology, or young-age brain tumors usually have unsatisfactory outcome. And side effects from standard radiation therapy, especially from craniospinal irradiation, are inevitable. Therefore, our center has developed treatment strategy with reduced radiation using proton, followed by tandem high-dose chemotherapy. The aim of this strategy is to improve the survival rate and to minimize side effects of radiation. For example, in the medulloblastoma, the most common brain tumor in children, if the tumor has metastasis, if there is large residual tumor, or if the histologic subtype is poor, the conventional treatment showed poor survival rates, and the late effects were significant, mainly because of the standard radiation. Therefore, our center developed treatment strategy which used reduced craniospinal radiation and tandem high-dose chemotherapy. The craniospinal radiation dose of our protocol was 23.4 or 30.6 gray. The survival rate was promising, and the side effects were less significant. Many patients entered college after treatment, and they got jobs. It was almost impossible with the conventional treatment of the past. In infants and young children's brain tumors, in the past, the effect of radiation therapy was particularly severe, so radiation was delayed as much as possible, but it resulted in frequent progression during chemotherapy and poor survival. So we implemented tandem high-dose chemotherapy to reduce or omit the radiation in this age group. With this strategy, about 60% of patients survived, even though the radiation was minimized. This is the treatment we are currently using. In the current protocol, we use intrathecal chemotherapy to further reduce the radiation dose. This strategy is also implemented in infant and young children's brain tumors. I'd like to conclude my presentation by summarizing the most important ideas that we've looked at. To improve the survival rates and to minimize late effects, Our center has implemented tandem high-dose chemotherapy from early 2000, resulting in many successes, especially in high-risk neuroblastoma and brain tumors. We are currently using many other new approaches, including precision medicine, to further improve outcomes of pediatric solid tumors. I sincerely appreciate your attention this afternoon.
Professor Lee for this very informative presentation. It is my pleasure now to present the third speaker, Professor J. Oakley. He is MD and PhD. He is Associate Professor at the Department of Pediatrics at Seoul St. Mary Hospital, and he will be discussing an important issue that you've just heard about, which is the transplant related. So is the title of the presentation is Patient Care after Allergenic Allergenic Hematopoietic Stem Cell Transplant in St. Mary Seoul Hospital. Professor Lee, the podium is yours.
Hello, my name is J. Oakley. I am a pediatric hematologist oncologist here at Seoul St. Mary's Hospital, affiliated with the Catholic University of Korea. And the topic of my presentation today concerns important complications after hematopoietic stem cell transplantation. So for my presentation today, I would like to introduce the clinical course of a case patient, and through this patient, I would like to emphasize major complications that may occur after hematopoietic stem cell transplantation, including acute graft versus host disease or GvHD, Cmv infection after transplantation, and methods of monitoring donor chimerism and primary disease after transplantation. So first, I would like to focus on acute graft versus host disease or GvHD. So the patient is a 10-year-old girl who was previously diagnosed with Philadelphia chromosome positive acute lymphoblastic leukemia, so a very high-risk subtype of ALL. She achieved complete remission with our 4-drug remission induction chemotherapy regimen. In terms of the long-term therapy for pediatric pH-positive ALL, many institutions around the world now undertake chemotherapy combined with imatinib without undergoing transplantation in first CR. However, at our institution, our policy so far has been to undertake allergenic transplantation in first CR after treating with chemotherapy combined with imatinib. So this patient also received an HLA fully matched to unrelated peripheral blood stem cell transplantation based on a conditioning combining total body irradiation, cyclophosphamide, and antithymocyte globulin. Around 2 weeks after transplantation, the patient complained of large amounts of diarrhea and abdominal pain, although she had shown engraftment. And a colonoscopy was done, the gross features of which are shown in this picture, and biopsy was done also. At around the same time, the patient showed an erythematous papular rash covering her face and both her hands. If we look at the complete blood count, the white blood cell and the neutrophil showed recovery, although she continued to show anemia and thrombocytopenia. In the blood chemistry panel, there was mild elevation of blood urea nitrogen and creatinine, whereas the cyclosporin drug level was within normal range. So in terms of the pathophysiology of acute GvHD, I think we can consider 3 main steps. First, when the patient undergoes a conditioning with chemotherapy, with or without irradiation, the patient receives significant amount of tissue damage. After transplantation, the donor T cells recognize host antigen and undergo activation, starting the process of GvHD. And finally, cytokines such as TNF-alpha may worsen the GvHD-related inflammation. Once acute GvHD is diagnosed, it is necessary to accurately stage the extent of GvHD in each organ. In the past, organs with potential for acute GvHD involvement included the skin, liver, and lower GI tract, manifesting as diarrhea and abdominal pain. Skin is the most common organ for acute GvHD involvement, whereas liver is the least common organ for acute GvHD involvement. Recently, the category of upper GI GvHD was made to include patients who showed persistent nausea, vomiting, and anorexia symptoms, with no clear reason for these symptoms after transplantation. Once staging of acute GvHD is done for each organ, we then move on to the overall grade of acute GvHD for the patient. And in terms of therapy for acute GvHD, first-line therapy consists of a calcineurin inhibitor such as cyclosporine combined with steroids. And usually systemic steroids are started for grades of 2 or above. So in the clinical setting, the most common scenario for starting steroids after allogeneic transplantation for GvHD would be a stage 3 skin rash, basically a rash covering more than 50% of the patient's body surface area. And so this would be the most common indication, whereas for patients who have grade 4 GvHD, this is really a life-threatening situation requiring intensive care. So acute GvHD prophylaxis is an important component of the transplant regimen. Methods of acute GvHD prophylaxis include the incorporation of ATG as part of conditioning and administering either cyclosporine or tacrolimus combined with methotrexate. When comparing cyclosporine and tacrolimus head-on, the data seem to indicate that tacrolimus is more effective in decreasing the incidence of acute GvHD. However, in terms of overall survival after transplantation, there is really no clear difference between these two drugs. So either cyclosporine or tacrolimus is really acceptable as a means of GvHD prophylaxis. So usually cyclosporine or tacrolimus is given 1 or 2 days prior to transplantation, started intravenously initially. At 3 months after transplantation, if the patient remains free of GvHD, the dose of cyclosporine may be tapered. At 6 months after transplantation, the drug may be stopped, again, if the patient remains free of GvHD. Cyclosporine or tacrolimus is usually combined with methotrexate, and this is extremely effective in eradicating the alloreactive donor T cells. But due to the severe GI toxicity that may be caused by methotrexate, methotrexate is usually not given on a consecutive basis, but rather the administration is spaced apart. So a protocol of giving methotrexate on days 1, 3, 6, and 11 is a commonly administered regimen. One scenario in which there may be a high incidence of acute GvHD is the haploidentical donor, family donor transplant setting, since in this case, the donor and the patient share only one haplotype. So methods of preventing GvHD in this case would include using ATG as part of conditioning, ex vivo T cell depletion by either CD34 positive selection or CD3 and CD19 negative selection of the graft, or giving post-transplantation cyclophosphamide on days 3 and 4 after transplantation. In this case, the rationale for post-transplantation Cy is that cyclophosphamide is extremely effective in depleting the alloreactive T cells, whereas the important stem cells remain relatively resistant to cyclophosphamide. Next, in terms of acute GvHD treatment, there really has not been much progress compared to the past. So first-line therapy remains steroid combined with a calcineurin inhibitor. Once first-line therapy is started, response to treatment should be decided after at least 1 week of therapy. If the patient continues to show poor response, then various second-line agents may be considered, including low-dose methotrexate given on a weekly basis, anti-TNF alpha agents such as infliximab or etanercept, or mycophenolate mofetil. And these agents are administered to patients in our department who show a poor response to first-line therapy. So going back to our case patient who showed engraftment but also showed a large amount of diarrhea after transplantation, the colonoscopic biopsy result was consistent with acute GvHD. For patients who show a significant amount of diarrhea after transplantation, it's always necessary to differentiate between acute GvHD and Cmv enteritis. However, in this case, the biopsy stain was negative for cytomegalovirus. So we were able to clearly diagnose stage 1 skin and stage 1 lower GI tract GvHD, resulting in an overall grade of 2. As I mentioned earlier, for patients who have an overall grade of 2 or above, these patients are usually started on systemic steroids. So our patient was also started on methylprednisolone at 2 milligrams per kilo per day while maintaining cyclosporin. And this regimen resulted in gradual resolution of both the diarrhea and the skin rash. Next, I would like to move on to the second topic, which is post-transplantation CMV infection. So going back to our case patient, as I mentioned, the patient showed a good response of the skin and GI Gvhd to the combination of cyclosporin and steroids. However, although the patient remained asymptomatic, the follow-up plasma cytomegalovirus RQ-PCR level showed a clear increase from 1,200 international units per milliliter to 29,000. So if we first look at the disease course of cytomegalovirus or CMV, after primary infection, the virus may infect monocytes and myeloid progenitor cells, establishing a latent infection. And afterwards, during a state of profound immunosuppression, as may occur after allogenic transplantation, the virus may reactivate, resulting in CMV infection and subsequent CMV disease. So the rate of CMV reactivation after allogenic transplantation really depends on the serology for CMV for both the donor and the patient. So for CMV positive patients, the rate of reactivation is around 60 to 70%. For CMV negative patients who receive transplant from a CMV positive donor, the rate of reactivation is around 20 to 30%. Risk factors for CMV reactivation include transplant from a CMV negative donor to a CMV positive patient, treatment for either acute or chronic Gvhd, since this would increase the overall state of immunosuppression, HLA mismatch transplantation, cord blood transplantation, and any form of T-cell depletion therapy that is done to prevent Gvhd, such as the use of ATG, alemtuzumab, or post-transplantation Cy. In terms of the diagnosis of CMV infection, the recommended method is real-time quantitative PCR using either blood or plasma. And monitoring should be done at least weekly for the first 100 days after transplantation, so the early period when the patient is really immunosuppressed. The monitoring regimen that we use currently at our department is based on RQ-PCR levels weekly up to 3 months after transplantation, every 2 weeks up to 6 months after transplantation, and monthly up to 1 year after transplantation. And the frequency and the duration of monitoring may increase for patients who have Gvhd. In terms of early therapy for CMV infection, we can consider either prophylaxis or preemptive therapy. First, concerning prophylaxis, this is not usually done by centers who undertake allogenic transplantation, mainly because the conventional antiviral agents that are used for prophylaxis may cause significant myelosuppression. However, a recent phase 3 trial reported on letermovir, which is a novel anti-CMV agent given in the prophylactic setting for CMV seropositive patients. Importantly, in the study, they found that patients who received letermovir had a significantly lower incidence of CMV infection compared to patients who received the placebo only. And this was with no increase in myelosuppression caused by letermovir in the patients who received this drug. So I think in the future, this drug letermovir may have a significant role in the prophylactic setting for patients who receive allogenic transplantation. In contrast to prophylaxis, the preemptive therapy is commonly used throughout transplant centers throughout the world. And to understand clearly the definition of preemptive therapy, it is necessary to clearly understand the definitions of CMV infection and CMV disease. So concerning CMV infection, this is when the patient remains asymptomatic, although virus or DNA is detected in either blood or plasma. In contrast with CMV disease, the patient experiences major organ-specific symptoms due to the continued replication of the virus, and these symptoms may stem from diseases such as gastroenteritis, pneumonia, hepatitis, or retinitis. So the preemptive strategy of CMV infection really refers to treatment starting in the state of CMV infection. That is when the patient remains asymptomatic, although virus or DNA replication has been confirmed. So first-line agents for CMV infection include either ganciclovir or valganciclovir. The strategy at our institution is to first start off with ganciclovir, the main toxicity of which is bone marrow suppression. Once treatment with first-line therapy is done, it should be given for at least 2 weeks prior to determining a response. If the response is poor, then second-line agents such as foscarnet or cidofovir may be considered. However, these agents are noted for significant renal toxicity. So now, going back to our patient who showed a very good response to the acute Gvhd therapy, but showed an increase in the CMV RQ-PCR from 1,200 to 29,000. Looking back on this patient, we can see that the major risk factors for CMV infection in our patient included initial CMV seropositivity, previous diagnosis and treatment for acute Gvhd, and the use of ATG as part of the conditioning regimen as the patient received an unrelated donor transplantation. So the patient was started on ganciclovir preemptively for asymptomatic CMV infection, and after 2 weeks of therapy, a follow-up CMV RQ-PCR study showed that she had reverted to negative status. And finally, I would like to talk about methods of monitoring donor chimerism and primary disease after allergenic transplantation. So again, now going back to our case patient who showed a good response to both acute Gvhd and CMV therapy. The donor chimerism study done at 3 months after transplantation using peripheral blood showed 98% donor chimerism. Bone marrow study done at the same time showed around 30% cellularity with full engraftment. However, RQ-PCR for the Philadelphia chromosome showed a clear increase from 0 prior to transplantation to clearly detectable levels. So hematopoietic chimerism refers to the percentage of donor and patient cells following allergenic transplantation. Although definitions may vary, full donor chimerism usually refers to more than 95% donor cells. Recipient chimerism refers to less than 5% donor cells. And anything in between is really referred to as mixed chimerism status. The intensity of the conditioning regimen prior to transplant has a major role in determining the chimerism status after transplantation. So for example, for patients who receive a myeloablative conditioning regimen, you would expect these patients to achieve full donor chimerism after transplantation. However, for patients who receive a non-myeloablative or reduced intensity conditioning regimen, mixed chimerism status may also occur. Methods of measuring donor chimerism status after transplantation have varied with time. The most common method of measuring chimerism today would be PCR of short tandem repeats or short segments of DNA that are repeated. The number of repeats vary according to each person so that the results of STR-PCR may be individual specific. If we now look at the results of STR-PCR in this study, we can see a clear discrepancy in the patient and donor profiles, and after transplantation we can see that the patient has converted to full donor chimerism. However, in this STR-PCR analysis, the patient after transplantation shows mixed chimerism status, with some features consistent with the donor, whereas some features of the patient remain unchanged. So mixed chimerism status refers to any percentage that is neither full donor chimerism nor recipient chimerism. This is more likely to occur after reduced intensity or non-myeloablative conditioning. If there is progressive mixed chimerism, that is, if there is continued decrease in donor cells with time, then the overall results may be indicative of relapse of malignant disease or potential graft rejection. However, I think it's also important to understand that mixed chimerism for some non-malignant diseases and some genetic diseases that require allogenic transplantation, mixed chimerism status in itself may be sufficient and curative. Next, I would like to move on to disease monitoring after transplantation. Regarding hematopoietic stem cell transplantation as treatment for hematologic malignancies, it's important to monitor minimal residual disease after transplantation, as any remnant MRD may be indicative and may be a harbinger of subsequent relapse. Methods of monitoring MRD after transplantation are the same as those used prior to transplantation and include flow cytometry to check for leukemic cells with an aberrant immunophenotype, PCR to check for immunoglobulin and T-cell receptor rearrangements, and PCR to check for leukemia-specific fusion transcripts, such as the Philadelphia chromosome, as shown in our case patient. So first, regarding flow cytometry, multi-parameter flow cytometry may be done to differentiate leukemic cells with an aberrant immunophenotype, shown in red in these pictures, to differentiate these leukemic cells from normal regenerating cells. Second, PCR may be done to detect leukemia-associated immunoglobulin or T-cell receptor rearrangements. This method is widely applicable in ALL patients, and high-throughput sequencing methods, a study of which is shown here, which was done at our institution, has the potential for much greater sensitivity than other methods used to detect MRD. The main drawback of this method is that it is time-consuming and really quite labor-intensive. And finally, RT or RQ-PCR may be done to detect leukemia-associated fusion transcripts, examples of which are shown here for both ALL and AML. The main advantage of this method is that there are stable targets, but however, this method can only be applied to a subset of patients and cannot be applied uniformly to the entire cohort of patients that one would like to test. At our institution, our policy so far has been to undertake donor chimerism studies as well as bone marrow evaluation, including MRD testing at the first month after transplantation. So this is prior to initial discharge from hospital, as well as at 3 monthly intervals up to 1 year after transplantation if the patient remains in a stable condition. So again, finally going back to our case patient, the donor chimerism study done at 3 months after transplantation using peripheral blood showed 98% donor chimerism. So we were able to see that the patient maintained complete donor chimerism, at least as shown by peripheral blood analysis. However, a bone marrow study done at the same time to confirm the status concerning primary disease showed a clear increase in the RQ-PCR for the Philadelphia chromosome from 0 prior to transplant to detectable levels. So a patient was started on imatinib. A follow-up bone marrow RQ-PCR done at 3 months later showed that the patient had reverted back to 0. So the patient was maintained on imatinib for 2 more years before stopping treatment altogether. And this patient currently remains disease-free at this point. So in my talk today, I've tried to introduce a case patient, and through this patient, I've tried to emphasize major complications that may occur after hematopoietic stem cell transplantation, including acute GvHD, Cmv infection after transplantation, and methods of monitoring donor chimerism and primary disease status, including MRD monitoring after transplantation. I hope my talk has been helpful. Thank you so much for your attention.
Thank you, Professor Lee. Our next speaker will be talking about a subject that will be appealing for anybody in medicine, which is robotic surgery and the advances in robotic surgery. Professor Byung-So Min, MD, PhD. He is Professor of Surgery. Proceed, Professor, please.
Hello, my name is Byung-So Min. I will talk about the introduction of Severance Robotic and Minimally Invasive Center. I am the director of Severance Robot and Minimally Invasive Center, Severance Hospital, Yonsei University. Today, my talk will cover brief overview of robotic surgery at Yonsei Severance Hospital. And then I'll review our current result of robotic colorectal cancer surgery. And then I will also provide you some of the brief updates of recent brand new robotic system, SP robotic GYN cancer surgery and thyroid robotic surgery. So I will start from the overview of the robotic surgery at Yonsei. If you ask me to summarize what is the current status, what is the history of the robotic surgery at Yonsei, I would summarize it in one sentence. We have been the first and the best in the robotic surgery in Korea. We performed the first robotic surgery in Korea back in 2005, and we established the first robotic training center in Korea. Actually, I'm in the training center of robotic surgery in our hospital. Behind me, you can see our robotic system for training. And we have the best robotic surgical team, and we are also the best institution of robotic surgery. We have world's #1 case volume in robotic surgical procedures. So we started robotic surgery back in 2005. You can see the photos of the first generation of robotic surgeons. When we performed the first robotic surgery in Korea, actually nationwide broadcasting company came into our OR and they made the news in their evening news show program. So this is the installation status of the robotic surgical system in Korea. Actually, it's outdated. 2 years ago, probably 2 or 3 more case systems were installed since. But approximately, we have more than 60 systems installed in the Seoul metropolitan area. And the rest of the Korea have around 25 systems installed. Among them, our hospital has 8 robotic surgical systems installed. 2 of them are recent brand new SP robotic system, and 3 of them are XI, the 4th generation robotic system. And we also have 3 older systems. So Yonsei Severance Hospital has 2 main buildings. The one is the main hospital building. There we have operation suite we call main operation room, MOR. And we also have a cancer center building, separate building. And there we have a separate operation room. We call it COR, Cancer Center OR. So in each operation room, we have robotic systems installed. In MOR, we have 5 robotic systems installed. There, our robotic urology surgeons and ENT, hepatobiliary and pediatric, and the other surgeons are performing robotic surgery. We have more than 37 dedicated robotic surgeons and nurses. In Cancer Center Hospital, we have 3 systems installed. There we have endocrine cancer surgery, upper GI and lower GI cancer surgery, breast, gynecology surgery, and so on. There we also have more than 30 robotic surgeons as well as 12 dedicated robotic nurses. So this is the annual case number of robotic cases in Severance Hospital. Last year, you can see the numbers are numbers are constantly increasing year by year. Last year, we have exceeded more than 3,000 cases per year. This year, until July, we have exceeded 20 cases. You also know, this year we have a COVID-19 problem, so we may expect some of the decrease in case volume, but still we are performing more than 2,000 cases until July. And the cumulative number of robotic surgery in Severance Hospital is amazing. 2 years ago, we have exceeded 20,000 robotic cases. That was the world record. We were the first institution worldwide where more than 2,000 20,000 robotic cases were performed. And last year, until this July, we have performed 27,000 robotic cases so far. And we are expecting probably next year, the cumulative number may exceed 30,000 cases, which will be also world record. So Severance maintains number 1 in robotic surgery. We were the first. We performed the first robotic surgery in Korea. We have world's biggest number of the robotic cases. It explains more than 12% of total number of the robotic surgery in Korea. And we were the first institution to record 1,000 cases using a brand new robotic system, Davinci Sp. It explains more than 40% of Korea's total case. We also have largest number of the Davinci system in Korea. We have more than 68 experienced robotic surgeons, and we have published over 350 articles in a peer-reviewed journal. Actually, Severance Robot Surgery Training Center is located in Avison Biomedical Research Center. The history of the training center actually goes up to 2008, but recently we have moved the place to the brand new Biomedical Research Center. Here we have best training and research environment. We have a 6 operation table in 4 operation room, and we have a large facilities that are very similar to real operation room environment. So let me go on with the review of the results of the robotic colorectal cancer surgery at Yonsei. I'm also a colorectal surgeon here, and I'm going to share with you about the lessons we have learned from 15 years experience of a robotic colorectal cancer surgery. So our first Davinci low entry resection at Yonsei was performed in 2006 November. Actually, at that time, it was a hybrid technique, meaning we performed some part of the surgery with the laparoscopic instrument, and then rest of the surgery was done with the robotic system. At that time, the system was standard, the prototype of the robotic system. And since then, now we have 6 colorectal surgeons doing robotic colorectal cancer surgery, and we have performed more than 1,500 cases. And we actually were the pioneers in propagating the robotic colorectal cancer surgery. We established our own method to perform the robotic colorectal cancer surgery, and we published them in a peer-reviewed journal. And then we also developed the standard procedure of doing a robotic low entry resection. And recently we also published a new method to perform robotic colectomy using suprapubic inline port placement. So the history of procedure development, we've been with the whole system. The first generation, we used the hybrid system, and with the second and third generation, we developed our own fully robotic technique, and we trained those techniques to global surgeons. And now we have a brand new 4th generation XI system, and we also developed a newer system that fits to the brand new 4th generation XI system. So the case volume by year in our colorectal division, you can see most of our colorectal cancer surgery is done by laparoscopic instrument, laparoscopically, and the robotic surgery actually explains between 15 and 20% of the total colorectal cancer surgery. But I would say numbers is continuously increasing, although it is not very dramatic. So the proportion of the type of the surgery, you can see the back in 2005, open surgery was the most frequently performed procedure, but now it is laparoscopic surgery, and robotic surgery explains around 10%, 10 to 15 to 20%. So colon cancer, we've done around 99,000 cases, also mostly performed by laparoscopic surgery. In colon cancer, robotic surgery proportion is very small. That's because the benefit of the robotic surgery in colon cancer is still controversial when compared with the robotic rectal cancer surgery. So that's why if you see the proportion of the type of the surgery in colon cancer, robotic surgery explains around 2 or 3%. But in rectal cancer, actually it explains around 30% of the total cases. So if you see the proportion of the type of the surgery in rectal cancer, you can see the rectal robotic surgery explains around the 30%. And also laparoscopic surgery is the most frequently performed one. And then nowadays open surgery explains around 10 to 15%. So the case distribution of the robotic surgery, rectal cancer surgery explains more than 85%, and colon cancer only 8.5%. So 15 years of experience of robotic surgery at Yonsei, we have reviewed 1,532 patients in total. As I told you, colon cancer explains around 25%, and rectum explains around the 75%. So you can see the mean age is around 60, and you can see slight male predominance. BMI, fortunately, Korean patient has a lower BMI than yours. But I would say BMI of the Korean patient is rapidly increasing. So nowadays, if we include current patient only, around 5 years, then BMI would be as high as more than 26 or 7. In rectal cancer, more than 40% of the patients have received the neoadjuvant chemoradiation therapy. And in colon cancer, tumor location, more than 75% is left colon, usually sigmoid. And in rectal cancer, more than 80% of the patients has a mid or low-lying rectal cancer. Lymph node yields are very increasing. In colon cancer, it's more than 25. In rectal cancer, it's around 15. Because in rectal cancer, we consider a significant proportion of the patient has received the preoperative chemoradiation therapy. This number of node retrieve is acceptable. Circumferential resection margin positivity is below 4.5%, which is very increasing number. And the you can see the type of the surgical details, surgeries. You see around 20% of the patient have received ultra-low anterior resection with coloanal anastomosis, and only 2.9% of the patient received abdominal perineal resection. So nowadays, our sphincter preservation rate is more than 95%. Open conversion, which is very, very low, is way lower than global standard. In robotic surgery, colon cancer, our open conversion rate is below 1.5%. In rectal cancer, it's even lower than 1%, which is very, very encouraging number. And the length of the surgery, the operation time, it explains the skin-to-skin time. It explains around 4 hours in each surgery. Blood loss are acceptable, and the intraoperative complication rate are very acceptable. Short-term operative outcomes, fortunately so far we don't have any 30-day operation-related mortality. And 30 days operation-related morbidity rate is around 20%. Among them, anastomosis leakage rate is about 3.6% in colon cancer and around 6.5% in rectal cancer, which are very acceptable numbers. And the complication, severe complication, more than Clavien-Dindo classification 3A, explains around 8%. And the hospital stay, median hospital stay is 7 days and 8 days, which is longer than results from the Western countries. It's a mainly difference from the medical social system here in Korea, because all the hospital stay is covered by government insurance system. Korean patient doesn't need to pay more if they stay longer. So that's why our hospital stay, median hospital stay is longer than Western countries. Survival rates, overall survival rate in colon cancer is more than 90%. In rectum is 89%. Disease-free survival rate in colon cancer is around 85%. In rectum is around 75%. Survival curves of the colon cancer splitted by stage shows very acceptable results. In early stage, it's more than 90% overall, both overall and disease-free survivals. And in stage 3 colon cancer, overall survival rate is 87% and disease-free survival rate is around 83%. In rectal cancer, also in early stage, overall survival rate exceeds 90% and disease-free survival rate is around 85%. In the stage 3 rectal cancer, overall survival is 87% and disease-free survival is 62.5%, which are very acceptable. Operation time, we analyzed operation time in CUSUM analysis. Surprisingly, we found the case volume required to overcome the learning curve was higher than previously reported. In colon cancer, it's around 114 cases. In rectal cancer, it was even higher than 300 cases. So take-home messages from our 15 years experience of the robotic colorectal cancer surgery. It is very safe and feasible. But when we look into the learning curves, it is not easy at all. So it is very important to train expert surgeon who can perform the very fluent robotic colorectal cancer surgery. We are also very proud of our training system in robotic surgery. We have proctored many surgeons in worldwide. We've been doing proctorship of the robotic colorectal surgery in everywhere. So let me move on to the current recent updates in Davinci Sp System. As I mentioned previously, we have exceeded more than 1,000 cases of the Davinci Sp System. And the system profiles expands, covers variety of specialty. But today I will specifically cover GYN and the thyroid Sp System surgery. For GYN cancer surgery, we have superstar GYN robotic surgeon, Professor Sang-Hoon Kim. And thyroid cancer surgery, we also have another super expert robot thyroid cancer surgeon who is Professor Ki-hyun Nam. And I have, thankfully, they provided their own data for this presentation. So Davinci Sp System is a brand new robotic system which is dedicated for single port surgery. So different from current robotic system where there are 4 robotic arms, Davinci Sp System has only 1 arm. But in one robotic arm, it actually has a smaller 4 robotic arm incorporated in robotic 1 arm system. So you can perform very equivalent to single port surgery. So what's the trend of the SP procedure in Korea? Actually, most of the SP procedure is done by head and neck surgery for transoral SP single port robotic surgery, and then followed by gynecologic single port robotic surgery, and then general surgery. General surgery usually is a thyroid and cholecystectomy. So GYN robotic surgery at Yonsei, still the majority of the number is XI system, but recently in this year the proportion of the SP system have reached near half of the total robotic surgical system. So gynecologic operation cases by single port Davinci Sp robot, benign cases 95 cases and cancer 22 cases. So endometrial cancer staging surgery, which is very challenging and very extensive surgery, can be done by Davinci Sp single port system. So in operation theater, it looks like this. Robotic arm inserted through single small incision at the umbilicus through the dedicated port system. So after the surgery, you can see the scar is really minimal. So this is the immediate post-op scar photo. So after a few months, scar actually disappears away. So patients are very happy. This is the case of the first Davinci Sp endometrial cancer surgery 2 years ago. So you can see the specimen is very intact and the operation scar is amazing. So when we compare this Davinci Sp scar with the current conventional laparoscopic single port surgery, the scar size are almost the same. And actually it is hidden by umbilicus. As I mentioned, a few months later, you cannot see any scar at all. So patients are very happy because GYN patients are females and they are very happy with their cosmetic results as well as good oncologic results. And also we have done more than 10,000 cases of a robotic transaxillary thyroidectomy so far. But recently, our thyroid surgeon, Professor Gvhd, have started a robotic single port transaxillary thyroidectomy. So the current standard of the robotic transaxillary thyroidectomy looks like this. You make a single big incision at the axillar, and through there you insert 3 robotic arms, and which are very bulky. So because the scar is located at transaxillar area, axillar area, it is hidden, but actually skull length is quite long. So during the robotic transaxillary thyroidectomy, you make a 3.5 centimeter incision long and make a flap all through the axilla to the neck to reach the thyroid. So in real operation theater, it looks like this. They use specialized robotic retractor so that they the retractor lift up the skin flap. So in the operation field, it looks like this. You can see the Davinci Sp robotic arms fluently dissect the tissues around the thyroid gland. So the recent clinical result of the after transaxillary single port robotic thyroidectomy, patients are very young. The mean age of the patients are 35. Of course, almost all of them are female, and mostly is thyroid papillary cancer. And their BMI, because those are young women, BMI is around 21. Preoperative hospital stay is only 3 days. So tumor size is around 1 centimeter, usually micropapillary carcinoma. And the complication rate is amazing. We don't have any recurrent laryngeal nerve injury, and we only have a transient hypoparathyroidism, which are fully recoverable after a few days. And the postoperative pain score is amazing. After 2 days of the surgery, patient actually complains no significant OP pain at all. So conventional robotic surgery, the photo is on your right. You can see the bulky robotic arms are inserted through a long single transaxillary incision. But in single port SP robotic surgery, you have a very small axillary incision, and operation field is not very crowded because we only have a single robotic arm. And the operation scar is amazing. You know, after this is a postoperative scar after robotic thyroid cancer surgery, because they make a small incision through the skin crease in axillary area. After a few months, you cannot really recognize any visible scar in their axilla. So benefits of the SP single port transaxillary robotic surgery start. It's technically very feasible because conventional thyroid robotic surgery, there are 4 robotic arms and all those arms are fighting each other. But in single port robotic surgery, there's only 1 robotic arm, there's no fighting anymore, and very comfortable console handling, and operation time is very competitive, only around 1 hour, and the operation results are very satisfying. For the patient, cosmetic outcome is maximized, and postoperative pain and early recovery due to the smaller wound is guaranteed.